It is my distinct pleasure to introduce a physician whose career has been so deeply rooted in medical education and clinical excellence. This is Dr. Cyrus Askin. Dr. Askin is homegrown. He trained at the College of William and Mary for undergrad. He followed that with his medical degree at EVMS. He then completed his residency at San Antonio Uniform Services Health Consortium in Fort Sam, Houston, Texas. And he was a chief resident there as well, followed by his fellowship in pulmonary critical care medicine at the same institution. He was also a chief fellow there. He's currently medical director of the ICU at William Beaumont Army Medical Center at Fort Bliss, Texas, as well as associate program director for the IM residency. He's developed curriculum in several different areas, including clinical reasoning, critical care, and simulation. In his spare time, he does a lot of push-ups at the gym, I'm told. He hangs out with his wife, Caitlin, and his two boys, and his new dog, who he gave the most internal medicine-esque name ever, named Osler, or call him Sir William for short, I assume. His passion for medical education led him to become the senior producer for the Curbsiders Internal Medicine podcast. He is now the co-host and founder of the podcast Critical Care Time. Clearly, he knows how to capture our attention on our way to work, in the car, listening to his podcasts. And so hopefully he could still capture your attention today while you are feasting on your Subway lunch boxes. So I will hand it over, Dr. Cyrus Askin.
That is a very flattering introduction. Thank you so much. I'll try to keep an eye on the chat. If something gets cut off, or if you don't hear me, just drop something there, or someone just start waving your hands, because I can see you guys, which is very creepy, I know. I do have like 450 or so slides to get through today, so I better get started. I'm just kidding, I don't have that many slides. Again, yes, it is a joy to be here. I wish I could be there in person. Hopefully, if I play my cards right, I'll get a repeat invitation, or perhaps not. We'll see. But yes, I have very fond memories of EVMS, of Ghent. We lived over in Colonial Place. That was the first home that I had. Was over on Virginia Avenue. One of my very dear friends for life, Dr. Nate Gordon, and I were really close in school together, and his wife as well. So this does feel like a bit of a homecoming, and I'm very grateful to be able to talk to you guys today. As the title slide belies, we're going to be talking about ARDS, which is one of my favorite things to discuss. And so let's get started. Okay, a lot of this you guys already saw. Just a kind of a brief bio for me. I did train at EVMS, of course. I'm one of the senior producers for the Curbsiders, and then several years ago, I decided to start a podcast with my colleague Nick Mark, Critical Care Time. If you get a chance, you should listen to it. I think it's pretty decent, but I am, of course, biased. So this is what we're going to be talking about today, kind of a little outline of ARDS. And really my goal is going to be to hit some bread and butter topics for you guys, things that are going to be perhaps even board relevant. And then we're going to talk about some things that are sort of on the horizon, exciting new endeavors in the world of ARDS, things to maybe be on the lookout for. So let's get started. So, as you guys probably already figured out by the title slide, ARDS stands for Acute Respiratory Distress Syndrome. It's essentially a clinical syndrome of acute severe lung inflammation and injury. And in ARDS, there's an inciting injury, something like sepsis or pneumonia, which causes alveoli to fill with fluid and collapse, leading to this profound hypoxemia and essentially stiff lungs, which are difficult to ventilate. It's important to realize this is not due to heart failure. It's non-cardiogenic pulmonary edema. Now, there can be an element of heart failure associated with ARDS, but it cannot be the driving force. You may be wondering, how common is this? Well, it's pretty darn common, especially in our ICUs. Roughly 1 in 10 patients and nearly 1 in a quarter patients on a ventilator will develop ARDS by diagnostic criteria. Despite how prevalent this is, the outcomes are still poor. Mortality ranges based on severity, but 35 to 40% is not an unreasonable aggregated estimate. The majority of folks, as you can imagine, that die from ARDS die of severe ARDS. This is not a new diagnosis. It was first reported in 1967 in a group of patients with respiratory failure. And really, it's taken the last, 50, 60 or so years to sort of define it a little bit better and improve our management, although certainly we're not perfect. One of the things we'll touch on today is the most recent 2023 kind of expert consensus definition of ARDS, building upon the classic Berlin criteria. And so we're going to get to that in just a little bit, among many other things. So in terms of how often ARDS happens, like I said, it's pretty frequent in the critical care setting, about 10% of your ICU patients and nearly a quarter of those on the vent. This translates to millions of cases of ARDS globally each year. And you guys may have not been in the midst of the COVID pandemic. I was as a fellow. That's really like that was my bread and butter as a fellow, was COVID ARDS. I can assure you it's a very real, very significant disease process that we really need to be comfortable managing. The severity of ARDS, like I said, does manage a lot. It does matter a lot as it relates to outcomes. So mild ARDS, the mortality may be closer to 20, 25, maybe 30%. But like I said, severe ARDS gets you close to a coin flip. And then it's also, I think, worthwhile to note that just because you survive ARDS, it doesn't really mean that life is going to be, roses and rainbows and unicorns and butterflies on the back end, right? So a lot of these folks have a prolonged hospitalization, then require a prolonged recovery, and they may have persistent muscle weakness, reduced lung capacity, post-ICU syndrome to include, post-traumatic stress disorder. So all very real problems that can manifest after you've quote unquote gotten better from ARDS. Like I sort of alluded to before, during the COVID pandemic and really like 2020, 2021, when things were pretty hot and heavy, there was a surge of ARDS cases, more than really a lot of us have ever seen. And really, at that time, we sort of globally had this raised awareness of some of the management strategies, proning patients, ECMO, and that was not just us as clinicians, but also the public medical community. Even now in 2025, as we're seeing those severe cases of COVID pneumonia ebb, we're still seeing plenty of ARDS from other causes, whether it be flu, multifocal pneumonia, sepsis, et cetera. And so it continues to be a major critical care issue. I want to remind you guys that really ARDS is not just a single disease, but it really is a syndrome with many causes. We can classify those causes as either being direct on one hand or indirect on the other. Those direct injuries that can really impact the lung directly are kind of that one category. And so that would be, for example, a pneumonia. So bacterial, viral, what have you, that would be a direct insult to the lungs resulting in ARDS. Aspiration of stomach contents, gastric contents, another classic cause. The kind of acidity of the gastric content can cause a chemical pneumonitis. You can also have ARDS from inhaling toxic smoke, chemicals, lung contusions from trauma, near drowning incidents where water floods the lungs, causing this acute inflammatory response. So many different things can sort of trigger ARDS in terms of those direct causes. But like I said, there's also the indirect causes, things like severe sepsis, even if the lungs are really just an innocent bystander. Similarly, pancreatitis, where you have this inflammatory cascade that can trigger ARDS. Cytokine storm that you can see in the setting of pancreatitis is again, lungs become an innocent bystander that can be severely affected. Massive transfusions that lead to trolley, severe trauma, all of those things can be secondary or indirect causes of ARDS. I think it's probably helpful to think of ARDS as this final common pathway. All these varied etiologies sort of funnel into this final common pathway, resulting in diffuse damage to the alveolar capillary membranes, edema, acute respiratory failure, so on and so forth. So even if someone's coming in with just severe sepsis, I think keeping your eyes on the possibility that they could manifest ARDS is only going to help you as a bedside clinician. So one of my favorite courses at EVMS with Dr. Buscher, if memory serves, was pathophysiology. I took notes for that class and distributed them amongst my classmates. I remember that vividly. And so really can't talk about any disease process without touching on pathophysiology. Although I would say I'm probably better at pathophys now than I was as a medical student. It was always a struggle for me for reasons that are beyond me. So in any event, ARDS is a condition where the normal architecture of the lung is really profoundly disrupted, as I discussed before. The alveolar capillary interface is ravaged by disease, and whether it's that initial injury is a direct insult like aspiration or sepsis, it doesn't really matter, because what ultimately happens is there's an inflammatory cascade that occurs, which I'm going to kind of show you guys in a moment. Those mediators flood the lungs, resulting in the alveolar capillary membrane becoming leaky, and then you sort of, for lack of a better term, can begin to drown on this proteinaceous inflammatory fluid. This is what we call the non-cardiogenic pulmonary edema of ARDS. If you look at this microscopically, for example, you can kind of see on that histologic slide in the background of this slide here, you see diffuse alveolar damage. The alveoli are filled with this proteinaceous fluid and debris, and hyaline membranes form lining the alveolar walls. This is the kind of classic finding of ARDS, kind of classic pathology. All this is going to lead to significant issues with gas exchange. Alveoli collapse as they're filled with fluid. You end up with blood flow that's, maybe passing through those alveoli initially, but not able to pick up any oxygen or drop off any CO2. We call that an intrapulmonary shunt. Then you also have significant VQ mismatch or ventilation perfusion mismatch in the setting of ARDS. And so the ventilation perfusion mismatch is probably a big part of why folks are difficult to oxygenate. But the shunting that you can see, the intrapulmonary shunting in particular, can result in very difficult oxygenation, because as you guys know, the hallmark of a shunt is that you could give them all the oxygen you want, and it's not really going to move the needle. Like I said, I was going to show you a slide that I patently stole from the interwebs. But the slide here, I think, does a pretty good job of illustrating on, the one side, on the left-hand side for me anyway, what a normal alveolus should look like, and that alveolar capillary membrane. And then on the other side, on the right-hand side, you'll see some of those inflammatory mediators and just a nice illustration of that inflammatory kind of deluge that rushes into the alveolus. When this happens, lung compliance drops drastically. So we talk about compliance in terms of, what is the amount of pressure required to sort of distend the lungs a certain volume. And so that's kind of how prone is the lung to expanding. Another way to think of it. So the lungs, as they become less compliant, they become very stiff. It's going to take a lot of pressure to expand the lung to a certain volume. It's important to note that the disease is somewhat, heterogeneous in terms of its effect on the lung, and that's what results in this so-called baby lung. So really, even though the person has, lungs that are X in size, only X minus Y is actually able to participate in gas exchange. And that's important when you think about how you ventilate these patients, because if you're not careful, mechanical ventilation can inadvertently over-distend the lung, those remaining kind of functional regions of lung, resulting in what we call VILI, or ventilator-induced lung injury. So that all being said, this sort of gives us a target to focus from a pathophysiology standpoint. We need to provide oxygenation and ventilation in a way that avoids exacerbating this diffuse lung injury, and we need to support the patient while their lungs are hopefully recovering. And we think about the phases of ARDS that they have to recover through as being the exudative, proliferative, and hopefully they don't make it to the fibrotic phase. The exudative is kind of that initial phase. It's acute inflammatory or response. You have diffuse alveolar damage. That's really happening in the first week. In the second week, patients will progress to this proliferative phase where you see some alveolar repair and fibrosis that occurs. And hopefully you can sort of nip things in the bud before they move on to the fibrotic phase, which leads to long-term fibrosis that's really not recoverable. There's not a lot we can necessarily do at that point, and that's when we're really talking about things like lung transplant. So moving on, we'll talk about some clinical definitions and diagnostic criteria as we get to some of the more, clearly clinically relevant elements of ARDS. So the first well-defined criteria for ARDS were actually established in 1994 by the American European Consensus Conference, the AECC, where they defined this term ALI, which we don't really use anymore, or acute lung injury, which is essentially like mild ARDS, and then everything else was ARDS. And so you can sort of see those criteria here. Several years later, we have the very famous Berlin criteria. That's 2012 revision of those initial criteria. And that's been the standard, or had been for quite a while, and sort of continues to be in a lot of ways. Now, to break this down, under the Berlin criteria, we have this acute onset. That's important. So the respiratory failure really should have occurred within a week of a known insult. So if someone's got, progressive hypoxic respiratory failure within days of developing pancreatitis, that's a great example of, ARDS. But if this is happening over, weeks to months, it's probably not ARDS, right? It's probably something else. We have to look at the patient's imaging. And in this case, we're talking about chest X-ray or CT scan. And we need to see bilateral lung opacity, so diffuse infiltrates or consolidations in both the left and the right lung that you can't really define as being due to a localized issue. So something is causing this diffuse disease within the lungs. As I mentioned already, I won't belabor the point. Heart failure can't really be the sole contributor here. Otherwise, it's not ARDS. It's an acute exacerbation of heart failure. We'll often do echocardiograms in these patients for a number of reasons, but one reason may be to rule out heart failure as the principal cause. And then we also can define ARDS in terms of severity: mild, moderate, severe. You see the criteria on your screen. And this isn't just kind of for funsies. It's also helpful when we talk to patients and their family members, so on and so forth, about mortality. So I'll quote the numbers again: 25, 30% or so mortality in mild ARDS, 30, 35% or so in moderate, and then greater than 45% in severe, I think is helpful to remember. Now, in 2023, sort of as the COVID pandemic was starting to ebb, or maybe a little beyond the initial phases of that ebb, I should say, we see the new global definition of ARDS expanding on the Berlin criteria. Why? Well, this really makes the diagnosis of ARDS more applicable globally and outside the ICU. So not everyone is going to have the benefit of being able to practice in a robust ICU like you guys have, but they may be in more of an austere environment. And so the goal overall here is to diagnose more people with ARDS, because when you evoke the term ARDS, it portends a certain approach to therapy, and that certain approach to therapy tends to save lives. And so break this down a little bit further, if you think about the Berlin criteria, you needed to be on a CPAP or a PEEP of 5 to make the diagnosis. So, if someone's not intubated or on high flow nasal cannula, they wouldn't meet the criteria. And so that's why we've developed this non-intubated ARDS or resource limited ARDS category. So if you could be on high flow now and have bilateral infiltrates or risk factors, so on and so forth. And you can even use this S to F ratio as opposed to needing an arterial blood gas to clinch the diagnosis. And that's helpful, in areas where you might not have access to a blood gas analyzer. And then there's also, ability to not just use chest X-ray or CT, but ultrasound to make the diagnosis, assuming you have an experienced operator using that ultrasound. So the kind of combination of using the oxygen saturation, the S to F ratio, ultrasound to identify things like B lines, hepatization of the lung, so on and so forth, we call that the Kigali modification to the ARDS definition, because it builds upon a proposal from Kigali, Rwanda, which was sort of the purpose of which was, again, to underline the importance of making the diagnosis in these resource-limited environments. If you're not looking for ARDS, it's actually fairly easy to miss, because you can sort of describe it without evoking the term, and then you're not going to initiate the therapies that you need to be using to treat these patients. So here on your screen, you can see sort of some examples of ARDS now based on that 2023 definition. So you can see the classic patient at the top, someone who's on high flow nasal cannula in the middle, who's making the definitions based on S to F ratio and the fact that they're on high flow. And then finally, someone who's actually on 15 liters face mask, so not on any sort of pressurized therapy, but they have a good story and they have ultrasound findings demonstrating those B lines that you can see. Hopefully they come up on your screen there. But those are all cases where we're making the diagnosis of ARDS now in 2025, whereas prior to 2023, they wouldn't necessarily meet the criteria for the definition. All right. So we're now going to get to the really clinically relevant stuff, which would be the P's of ARDS. So if you've listened to the podcast episode on ARDS, some of this will be familiar, but it's like every time I give this lecture or talk about this topic, I add a P, right? So now I have 12 P's of ARDS. We're going to get through all of those here pretty quickly, but hopefully, we'll try to use our time wisely as we move on. So lung protective ventilation, this is the idea of low tidal volumes, low pressures. So in ARDS, we want to limit our tidal volumes to 6 mils per kilogram of predicted body weight and limit the plateau pressure to less than 30 centimeters of water. And this comes from the ARMA trial from 2000, so a long time ago, long before I was in medical school or any of you guys were in medical school, a trial that demonstrated a mortality benefit. As a reminder, you guys can see kind of on the slide here, and hopefully, let's see if this will actually work. Hopefully you can see the, it looks like you can see my laser, hopefully. But you can see that there's at the top of this graphic here, looking at pressure over time, you have this peak pressure, this high region on the graph, and then there's an area where it plateaus. That area where it plateaus before you get down to the PEEP, or the positive end expiratory pressure, that plateau is essentially the pressure that your alveoli are under, so to speak, the pressure that they are enduring every time the ventilator goes off and delivers a breath, once the system sort of equilibrates. And so there's data to suggest we want to keep that pressure less than 30. We want to actually keep the peak pressure less than 40 if we can. Those are some of the classic metrics we look at when we talk about ARDS. There are other things we talk about, like stress indices and some more advanced measurements that you can make, but really this is kind of the tried and true when it comes to ARDS. What modes do we want to use? Well, if you guys have worked in the ICU before, you're probably familiar with some of these. Really, ACVC is not necessarily the superior mode, or really hasn't been proven to be the superior mode in any major studies that I'm aware of, but it is the study that was used in a lot of the ARDSNet trials. In fact, I think all of the trials that fall under ARDSNet were done with ACVC, but please correct me if I'm wrong there. You could potentially opt to use ACPC, so that would basically be a pressure-controlled mode targeting pressure targets as opposed to volume targets. So there may be situations where you would do that. But you probably don't want to use this PRVC mode for ARDS. PRVC, or ACVC with autoflow, or ACVC plus, depending on the ventilator you use, is essentially a hybrid mode where the ventilator will adapt the pressure support to achieve the tidal volume, losing the least amount of pressure. This sounds great, and it works pretty well for a lot of the patients in the ICU, but in those for whom you want to achieve lung rest, you really want to make sure that every breath they take is a rested breath. You're not trying to stress their lungs out, so to speak. PRVC can be problematic because as the patient is dynamic, so goes the mode. And so the mode can provide, more or less support as the patient is evolving. And there may be times when they're getting less support because, they happen to be needing less support at that point in time, but then they get a bit volume overloaded, and it takes a little while for the ventilator to catch up to the amount of pressure support that they need to achieve the targeted volumes. So most of us try to stay away from that mode in ARDS. Now, I talked a little bit about the peak pressures already, but there are some other elements of lung protective ventilation and PEEP. Oxygen toxicity, so we want to try to target a little bit of a lower O2 goal than we may be used to. We know that free radical production is an issue and can be problematic in ARDS. We also have this idea of permissive hypercapnia, which could have been another P in and of itself, but I decided to spare you guys. That's basically accepting the fact that sometimes these folks are going to be difficult to ventilate, and oxygenation is what's really important. Now, that may minimize volume trauma and barotrauma, but you can't really do it in right heart failure. Why? Because what we do know is that as that pH drops and the CO2 rises in the pulmonary vasculature, we see the opposite of pulmonary vasodilation. So you see pulmonary vasoconstriction. We know that oxygen is sort of the poor man's pulmonary vasodilator. Well, high CO2 levels will do the reverse. They're going to cause pulmonary vasoconstriction, which becomes an afterload problem for a failing RV. So you can't really do that in that situation. I've already talked about the peak pressure. PEEP, so that's essentially that pressure that's going to keep your alveoli open, allowing better oxygenation, better ventilation. It's going to prevent adolect trauma, i.e. trauma that can occur as the alveoli open and close repeatedly. We have in normal healthy circumstances, we have volume in our that's sort of like always in our lungs. That's our residual volume that we can't breathe out. This is sort of like adding to that, recognizing that your residual volume is often the first volume to go in the setting of ARDS. So we're trying to just keep things open and allow for oxygenation and ventilation. Another semi-advanced concept in ARDS is this idea of driving pressure, which is keeping that plateau minus PEEP less than 14. And the idea there is that you're trying to minimize kind of the tendency towards atypical trauma or the tendency towards like rapid changes or significant alterations in pressure within the alveoli. And just recognize when I say we're trying to keep these things, you're going to take what the patient's going to give you. Sometimes you can't achieve your goals to a T, but it may be good enough, and you may have other metrics that you're following to ensure that it's okay, that what you're doing is maybe coloring outside the lines. But sometimes if you're really struggling, that may be a situation where you need to look at something else, another treatment strategy, and we'll talk about that a little bit. Just so that you guys are familiar with this is a PEEP table. So this is something that's nice. You can sort of give your respiratory therapist this PEEP table to help them titrate the patient's ventilatory needs in your absence if you're rounding on other patients based upon the strategy that you determine. So from a basic standpoint, you can pick a high PEEP or a low PEEP strategy, and then conversely a high FiO2 or low FiO2 strategy, depending on what you think the patient's going to respond to. In 2001, we kind of like didn't have the most refined approach to this, but I'm going to show you towards the end of the presentation where this could actually be helpful using some more recent literature that we have to play with. Okay, moving on. So turning our ARDS patients or proning them on their bellies, as you guys may have seen, is really one of the most effective interventions we have for severe ARDS. Every time I show a patient or show like a team a rotaprone bed or talk about the idea of proning, I often joke with the trainees, it's kind of like a rotisserie chicken model. You just keep them rotating constantly. That's not what we actually do, but I just think the imagery is a little bit humorous. And I'm sorry, dark humor is like a necessity in the ICU. Otherwise, I think it'll eat you alive. But we're not actually rotating them like a chicken at Costco. We're flipping them on their belly for about 16 hours a day and then on their back for 8 hours. The data for this comes from the PROSEVA trial, and then there have been subsequent trials to support it in 2013, which really was a game changer in the world of ARDS. They defined severe ARDS as a P to F ratio less than 150, and they took those patients early in their course and proned them for 16 hours a day, and then put them back on their backs for 8 hours a day. And now this idea of institutionalized tummy time is strongly recommended for ARDS management. Why does it work? Well, if you think about the lungs, you think about the anatomy of the lungs, the majority of your lung tissue is oriented posteriorly. So if you're laying on your back all the time and you've got these wet, inflamed, heavy lungs, a lot of the majority of your volume or potentially effective volume is sort of ravaged by disease and pulmonary edema. So if you flip these patients, the idea is you can distribute some of that, open up the posterior lungs, allowing them to participate in gas exchange, and maybe get that patient to do better. You actually see a significant improvement in ventilation perfusion mismatching and improvements in oxygenation. Now, there are some practical considerations here that I do want to talk about. We're talking about really moderate to severe ARDS using our current definitions, especially patients who are on high FiO2, high PEEP strategy, still hypoxemic. So we're going to start with just kind of plain old lung protective ventilation. Why? Because many places do not have rotaprone beds readily available. They were very hard to come by during the pandemic. And so you're reliant on people to flip patients, which is fine. Certainly we can and do that, but it's time consuming for the staff. It does require coordinated effort. And you can have device dislodgement. I remember a patient that, for reasons beyond me, they had the endotracheal tube affixed to the bed rail. And they told me they were proning this patient. I was on my way over there, and then I hear the code blue, run over there, and they inadvertently flipped the patient with the endotracheal tube affixed to the bed rail. The tube essentially came entirely out of the patient, and they were on a PEEP of like 20 and an FiO2 of 90. That patient did not do well. They died that night. So it's a big undertaking. And furthermore, there are significant hemodynamic shifts that can occur when you prone a patient that can result in them having severe bradycardia, PEA arrest, or they can have, they may tolerate it, but then they have kind of severe hypercapnia. So sometimes patients ventilate very poorly when you do this, just due to that change in their position. So it's not a free maneuver, but it is a tried and true and proven maneuver, and it's definitely something that needs to be considered in the appropriate patient. Moving on to another P, which is, I'm using prednisone, but really we're talking about dexamethasone here in particular. So steroids, corticosteroids have been debated in ARDS management for quite a while. Recently, though, we're really starting to see pretty broad support. There were small trials in the 80s and the 90s that really did give some mixed signals on steroids, some showing improvement, others raising concerns about infection and myopathy. And so for a while, steroids were not recommended in ARDS. Except perhaps in late ARDS with unresolving fibrosis, and even that's controversial because there wasn't a whole lot of data to support it being effective in that frame. So in 2020, we did have a well-conducted trial, the ARDS trial, in moderate to severe ARDS, and they said they used a P to F ratio of less than 200, and that did demonstrate a higher that did demonstrate, that a higher dose of dexamethasone, when given, improved ventilator free days and mortality. So that was 20 milligrams IV. Then we had the recovery trial during COVID-19 looking at a lower dose that also kind of reinforced the idea that steroids are beneficial. And so since then, we have the 2024 ATS guidelines that provide a conditional recommendation for the use of corticosteroids in ARDS. And so a lot of times for severe ARDS or folks that you're thinking about proning, we will initiate steroid therapy. You do have to watch for blood sugars, you do have to watch for neuromuscular weakness and the potential for immunosuppression. But recognize a lot of times these patients are on broad spectrum antibiotics already. And so that concern for immunosuppression is maybe not quite as important as trying to slow the progression of ARDS and help that patient recover. You're also going to get potentially a benefit if that patient's on vasopressors for using steroids, so another benefit there. And just a word on why are we using dexamethasone? Well, think about in sepsis, which is another topic I love to discuss. In sepsis management, you're using you're using a lot of times hydrocortisone, and you're sort of doubling down on your mineralocorticoid because you're adding fludrocortisone. However, in these folks, you really are trying to avoid additional fluid retention, and so that's why we use something that doesn't have mineralocorticoid activity, i.e., dexamethasone. Moving on, so paralysis or neuromuscular blockade is a somewhat controversial topic in the world of ARDS. We have really two seminal studies that look at paralysis and answer the question differently. Acurasis in 2010 showed a benefit, looking at cisatracurium, which is probably the preferred agent because of the way it's metabolized. It's metabolized, not through the kidney or through the liver, but through red blood cell metabolism. And then we had the ROSE trial, however, in 2019 that did not confirm a mortality benefit as seen by Acurasis. And so that's why really the guidelines that we have, the American and the European guidelines, are split in terms of the management of ARDS, and we're sort of left scratching our head. And so I think where the rubber meets the road when it comes to neuromuscular blockade is think about it in the patients who are you proning. Again, you don't have to prone patients you don't have to paralyze or provide neuromuscular blockade to those prone patients, but it's often done in tandem. So that might be an option. If you have significant ventilator dysynchrony, patient is not really breathing with the ventilator is constantly alarming, and you've already done all your appropriate troubleshooting, looked at the vent mode, looked at the circuit, etc., you could consider a trial of neuromuscular blockade, see if things get better. But overall, you want to make sure that you're doing it in a select patient population. When you've tried the other evidence-based tactics, those patients should be on DVT prophylaxis. You can definitely feed those patients if they can otherwise be fed, so you don't have to worry about magically paralyzing their smooth muscle. That's not a thing. So you can feed those patients. Please feed them. But yeah, so that's sort of like where we're at in terms of using neuromuscular blockade. Certainly, there are concerns with myopathy that is, you combine steroids and neuromuscular blockade. It's kind of setting the stage for post-ICU syndrome and significant post-ICU weakness. But I guess the argument would be it's better to be alive and weak than to be strong and 6 feet under. So now this is a little bit fringy as well, this idea of using pulmonary vasodilators. So this is not something that's been really shown to have a mortality benefit in ARDS, but in theory it can work and be helpful. So things like nitric oxide or epoprostenol are the drugs that are used, and it should be inhaled, right? Because we don't want to indiscriminately cause pulmonary vasodilator. We want to target the functionally useful parts of lung. So patients can breathe that medication. They're going to have that pulmonary vasodilator where the alveoli are healthiest, and that can help improve VQ matching, reduce shunting, it'll reduce the PVRs, pulmonary vascular resistance, and in turn help the right side of the heart. So it's all sounds good. It's just the data is not really there to make it part of your like usual armamentarium, right? When do I think about it? I think about it in patients who have done, again, all the sort of tried and true interventions. There may be going to be a possible candidate for ECMO or something along those lines, or in patients that clearly have right-sided heart failure, and it can be helpful in them. Parsimonious fluid and peeing. Now, this is something that really has been evidence-based, I think, even a little more so in recent years. It's clear that the dry lungs are happy lungs, is the easiest way to put it. So within ARDSNet, we had the FACT trial, which targeted CDP goals and basically found that you had some improvement in patient outcomes, not mortality, but improvement in patient outcomes when targeting a lower central venous pressure versus a higher central venous pressure, a more liberal strategy. Now, we know from evidence that we have in critical care in general that the CVP is certainly not the be-all and end-all. It's not the best measurement for really much of anything other than a surrogate for right atrial pressure, assuming that there's no significant valvular disease that's really throwing you for a loop. Certainly not a great measure for volume status in a vacuum. But what we've kind of taken this to believe is that if you're doing lung ultrasonography and looking for, looking at your B-line profile, looking at daily weights, you're probably better off keeping that patient drier than wetter. This was further underlined in the work by Seitz and colleagues in 2020, where they actually looked at retrospectively about 200 IC patients and found that being aggressive with your diuresis, so helping them get dry by making them pee, was associated with lower hospital mortality. So this has been part of my practice, is really just pushing the envelope with diuresis. And then sometimes you do have to lean on mechanical diuresis, i.e. Continuous kidney replacement therapy or CKRT or CRRT. There's not a ton of data from, we have a number of studies like Acute is one of the ones that comes to mind, several others that sort of like explore when to initiate CRRT in your critically ill patients. And the answer is shoulder shrug, we don't really know for sure. But certainly if the patient is not peeing and they have a dense ATM, let's say, and they're just getting more and more positive, you probably don't have a choice. Similarly, so this is sort of like peeing out your chest, I guess, would be pleural evacuation, right? So patient's got a giant pleural effusion, think about draining it. We know that sizable pleural effusions can impair your ability to actually breathe on the ventilator especially. And so drain those effusions, drain the pneumothorax if you can. The little guys that you're kind of struggling to see are probably not going to make a whole lot of difference, but draining these bigger ones is very helpful. And also you can send that off for testing. If this person has ARDS from multifocal pneumonia and, oh, by the way, they have an empyema or something that you weren't really tracking on, you get kind of a 2-for-1 there. Okay, so probably the most controversial topic that I'll discuss here amongst the P's of ARDS, this one had the question mark, if you remember on the first slide, is APRV, or airway pressure release ventilation. And this is the idea that, right here I've shown you, I'm sure you guys all have this like tattooed on your chest, but it's the alveolar gas equation. So the alveolar gas equation is a great way of understanding how oxygenation works with a mechanical ventilator. Your FiO2 is really going to give you the biggest bang for your buck. It's a multiplicative change in terms of the PaO2. Now, when we talk about pressure and why we use pressure to sort of help oxygenate, it's the idea of increasing mean airway pressure. It's essentially like increasing the atmospheric pressure artificially within the circuit. And so if you increase the atmospheric pressure, quote unquote, you increase that term that is in parentheses, and you can improve oxygenation, all else being equal. This is the idea behind APRV. So what we're doing is we're basically putting this patient, for lack of a better term, on CPAP with brakes, and we're allowing them to breathe at that high pressure as well. So they're not, no neuromuscular blockade in these folks. You're allowing them to ventilate when they're getting that high pressure, and then they're primarily ventilating, however, when the pressure drops. And that's what's kind of outlined here on the graphic on the right. There was a study by Zhao and colleagues in 2017, bilevel APRV. This one demonstrated an improvement in ventilator-free days. It was significantly greater in the APRV group as compared to the low tidal volume group. They found that there were significantly better markers of oxygenation and ventilation in this population, lower heart rates, higher blood pressure, less sedation needed, higher extubation rates. ICU length of stay was lower. A number of kind of optimistic findings. Their p-value for success was 0.001. So whenever I see something like that, I get a little bit skeptical because the rest of the data that we have doesn't really support it. Really, data not generally supportive of APRV. So I put this here as like something you should be aware of. Some institutions know how to use it. They use it regularly. They might use it up front even, but many places don't. I'll say that APRV requires institutional buy-in between the physicians that are a part of the group, between the respiratory therapists, and so on and so forth. It is a mechanism that has some theory behind it. It's often going to be unused or used very rarely, but again, it exists. Okay, peripheral oxygenation or ECMO. This is one of the last P's we're going to talk about before we get into some of the newer things that are on the horizon, or maybe almost ready for prime time. Peripheral oxygenation, i.e. ECMO, or VV-ECMO in this case, is the idea of draining venous blood and then returning blood to the venous side after it's been decarboxylated and oxygenated. So you're still using the heart, but you're essentially bypassing the lungs. The two big studies we have are CSER and EOLIA. CSER demonstrated survival-free of disability was significantly higher in the cohort randomized to receive care in the ECMO center. So 63% versus 47%, a number needed to treat of 7. However, those that were randomized to the ECMO center, 25% of folks did not actually receive ECMO. And so the question is, like, was it the team, or was it the modality, or is the answer just yes, it was both? CSER didn't really tell us the answer to that clearly. We then had the EOLIA trial, which unfortunately was stopped early and is a technically negative study, but was still highly suggestive of a survival benefit. So you had two groups in EOLIA, those that did and those that did not get kind of early ECMO. But those that did not, 28% of those patients actually needed rescue ECMO. So there was significant crossover. And so the thought is that maybe a little bit of a change in study design, plus if they actually enrolled the 330 some odd patients they wanted as opposed to just 249, they might have had a positive study. But as of now, we don't have an RCT that is really like clearly demonstrative of BV ECMO in these folks. Obviously, there's well, if the lungs aren't working, we've done everything else, we don't really have a choice. And that tends to be the way forward. But I will say there have been some post hoc meta-analyses that have demonstrated a survival benefit when ECMO is being used in those experienced centers. So aggregated data, pretty, somewhat optimistic, but we don't really have we don't have the ARMA trial of ECMO yet, and I'm not sure when that's going to come. Palliation, this is really important. I can't stress this enough. ARDS has high mortality, right? So you want to make sure that those survivors who are going to face a long path to recovery they know sort of what they're getting into. Have these discussions early and often with your patients and their families. And you just don't forget that palliation is part of patient care. Really cannot say that enough. Briefly, some things that don't work. We have this graveyard of ARDS drugs that are not helpful. There's a number of them there. I thought this idea of liquid ventilation was interesting. Basically, iatrogenic drowning of your patient using pre-treated perfluorocarbon liquid didn't really work when they tested it. And similarly, I remember during ARDS, there was this great article on rectal oxygenation, which I just thought was like the coolest thing ever. Also not ready for prime time and probably not the best way to oxygenate your patients if you really, think about it. So probably put the endotracheal tubes in the mouth and not in the rectum. Okay, so other things that don't seem to work. High frequency oscillatory ventilation. This is a ventilator mode you'll often see in the NICU. Doesn't really, not really helpful in ARDS. The studies that we have demonstrate possible harm, so I'm not going to belabor the point. Oh, I'm not sure what just happened. Did my screen stop sharing? God. Can you guys still see my screen? I'm sorry, so everything just kind of changed on my end.
Yes, sir. It stopped sharing.
Okay, let me see what happened there. That's weird.
Yeah.
1 second. Place current share. Sorry about that, guys. I'm not sure why that happened. Okay, we should be good now.
Yep. Thank you.
Perfect. Okay, cool. Okay, so continuing on. So yeah, HFOV, not something you guys really need to be terribly, I think, concerned about because you're not going to see it in the medical ICU. APRV, I've already kind of mentioned that, so I'm not going to belabor that any further. And then this idea of recruitment maneuvers, which you'll sometimes hear about, is this idea of like cranking the ventilator up to like a continuous pressure of 30 to 40 centimeters of water and then dropping it incrementally. Tends to really recruit a lot of alveoli to the point where it ruptures alveoli and can cause a pneumothorax. So not really all that helpful and can be harmful. Okay, so some future directions and conclusions that we're going to get to here. Really, as we have this growing understanding of the complexity and the pathophysiology of ARDS, coupled with advances in stem cell biology, there's sort of renewed interest in some of the therapeutic options that we have on the horizon. Things like mesenchymal stem cells being used for ARDS, potentially being able to modulate, regulate the immune response, facilitating regeneration and repair of lung injury. That's kind of this interesting concept. We're seeing post-ICU clinics, which I think is a great thing, especially for ARDS. I mentioned the mesenchymal stem cells, but precision medicine, we're going to talk about that a little bit more. And then this idea of these AI-powered ventilators that can take into account a number of variables to maybe do a better job than we can from breath to breath. And then finally, advances and changes in ECMO. So I just kind of breaking this down a little bit more, some emerging computational models that are looking at maybe integrating CT findings and ventilator parameters in the setting of our machine learning and artificial intelligence to change how the ventilator delivers a breath, just taking into account more variables than the human mind is able to calculate. That's pretty exciting. There's this idea of ARDS subphenotypes, which we're going to talk about. And then basically our next generation ECMO devices, smaller cannulas, better cannulas, improvements in kind of our understanding of anticoagulation, all of that may contribute to improvements in ARDS management. I talked a little bit about the mesenchymal stem cells and how there may be some benefits there in terms of lung healing that can occur. And then I just had to include this picture of this jolly man who's on high flow. I don't know why he's so happy to be on high flow nasal cannula, but we're seeing kind of more and more high flow nasal cannula being used, and I think that that's a continued area for growth. So some of the kind of future directions in particular I'm going to focus on are going to be this idea of AI and precision medicine approaches, which we're going to get to that here. When I talk about AI and what how it could be useful, one thing might be to utilize novel concepts or emerging concepts. So one is this idea of mechanical power and mechanical ventilation. So traditionally, lung protective ventilation is using low tidal volumes. We talked about peaks, we talked about plateaus, but mechanical power is going to integrate several parameters that can give you a more complete estimate of ventilator-induced stress and strain. And at least in this study, there is some data to support associations with high mechanical power and poor outcomes. Association is not causation. There haven't been RCTs looking at this yet, but the theory here is that you could have this as another metric in your ARDS patient that you're following. This is a pretty cool publication from actually a few years ago in a little known journal, Nature. I say that tongue-in-cheekly because Nature is like the holy grail for a lot of researchers. The researchers in this study built this tool called Vent AI using a type of machine learning called reinforcement learning. The tool was essentially trained on data from tens of thousands of ICU patients on mechanical ventilation, and it learned over time which choices, things like tidal volume, PEEP, FiO2, were more likely to lead in better outcome, or in this case, 90-day survival. So they basically had all of the data, and it was able to make those connections. The tool was then used to create a decision model where every 4 hours, the AI would recommend changes to the ventilator based on specific inputs. And then the results in these scenarios, they use kind of scenario-based model. These results were compared to what the clinicians did when faced with the same scenarios. And unfortunately for me and my colleagues, the machine did a lot better, much better, in fact, in the simulated outcomes in the sicker patients especially. It often would recommend, and kind of earlier would recommend lower tidal volumes, appropriate PEEP, avoided unnecessarily adjusting FiO2, and the recommendations were actually clinically reasonable and aligned with our current guidelines. So this kind of demonstrates that, like it or not, this is kind of probably the future of of medicine, and especially critical care medicine, is using these tools to help guide our decisions because of the number of parameters that these tools can take into account. And so not quite ready for prime time, of course, and I don't think that this is necessarily going to take our jobs as intensivists, but I do think it's going to augment us and allow us and function as like a force multiplier in the world of critical care medicine. Now, I want to kind of quickly get through this idea of ARDS phenotypes. And this is something we don't often think about, but there's this idea that not all ARDS is created equal, and we have these hyperinflammatory and hypoinflammatory phenotypes. And perhaps understanding which one is which could allow us to change the way that we treat our patients. In fact, there is evidence to support that these different phenotypes respond to ARDS therapies differently. And so in particular, like there was a study from Famous et al. In 2017 that showed that in those that were the higher kind of pro-inflammatory phenotype, higher inflammatory markers, those folks did better with a more aggressive volume strategy, so kind of more diuresis, than those that weren't quite as inflammatory in terms of their phenotype. Now, this was a recent study by Shuba and colleagues, where their objective was to investigate whether different ARDS phenotypes responded differently to PEEP. Now, remember back to that PEEP table, wouldn't it be nice to know who would be better for a high PEEP strategy versus a low PEEP strategy? And that's what they kind of set out to do here, looking at data from two studies, Alveoli and ART, A-R-T. These were the phenotypes. So you have your subphenotype A and your subphenotype B, just so that you guys kind of know what it is that we're looking at in these folks. The lower kind of A would be your less sick, B would be your sicker. And so here we can see in these graphics that basically your folks that were put on high PEEP that were kind of the lower inflammatory phenotype did worse, and vice versa in terms of mortality. So these findings really do suggest the need for personalized ventilation strategies, and looking at the inflammatory phenotype can be helpful in making those decisions. So, in short, that phenotyping and sort of this idea of precision medicine in ARDS is very exciting. It gives us this idea that maybe we have new targets that we can work towards. We can sort of stratify our patients differently, and that all of this can guide us towards better outcomes using evidence that is both currently present and perhaps on the horizon. Really, with that, I wanted to thank you guys. It's a picture of my family. I wanted to thank you guys for hosting me and letting me talk to you guys about ARDS, cover the, in this kind of whirlwind discussion, admittedly, there was a lot I wanted to get to. Sorry for the little technical snafu, but I wanted to make sure you guys had an understanding of where we've come from, where we are, and perhaps where we're going. And with that, I will take any questions that might be available in the time we have left.
Thank you so much, Dr. Askin. Does anyone have any questions? I had a question as a lowly internist. During COVID, we saw what seemed to be a higher mortality in patients that were intubated, and we kind of embraced that permissive hypoxia. Do you think that the reason for that is their hyperinflammatory phenotype? Do you think that there's any other specific reason why we tended to see a higher level of mortality in the patients that were intubated? And has that led us to any other kind of, ways of thinking of other disease processes in different ways because of it?
Yeah, so I think one of the things we found with a lot of our COVID-19 patients who had severe ARDS was that they did fit this picture of the pro-inflammatory phenotype. And that idea of tailoring management to the pro or kind of low inflammatory phenotype wasn't really widely adopted and still hasn't been widely adopted. So I do wonder in hindsight if that was if that idea had been a little more baked, so to speak. If maybe we could have made some headway. I think probably what I would say is the idea of high flow nasal cannula and non-invasive positive pressure ventilation. It's wonderful to be able to treat folks with these tools. I think where you can get into trouble, and this is what we haven't really figured out, is when you're letting someone really languish for long periods of time, taking these giant tidal volumes, very sick lungs, causing that and kind of adding fuel to that inflammatory fire. So I remember there'd be patients who'd be like on high flow or on high non-invasive for long periods of time. And even though one of the recovery subtrials supports using it as a primary ventilatory means, I think that we were so afraid of like the significant hypoxemia when you would do RSI on these patients and causing them to die during induction, that we would just like leave them out there for too long. And then when you intubate those patients after you've really just waited, I think you've set yourself up for failure. So I think that's kind of my perspective on it, if that kind of makes sense.
Gotcha. Thank you.
I see there's a question in the chat.
Your letter of rec writer has a question. Dr. Flemmer?
Thank you very much for your talk. I remember you well, and a local boy who's made good.
Dr. Flemmer, it's an honor to have you join. I think about you not infrequently, sir.
Well, thank you. There was a Clovis trial in the New England which looked at sepsis and said that giving lenient fluid was not as good as giving a lot of fluid was not as good as giving lenient fluid. Do you look at the phenotype very closely, because sepsis and ARDS are often part of a continuum?
Yeah, so I think you're right, and they're often they're sort of nasty bedfellows, the two of them. I think that in this day and age, when I'm making clinical decisions, it's me with an ultrasound in one hand and the EMR in the other. And so I think both in sepsis and in ARDS, I am considering the inflammatory mediators that we have available. Unfortunately, a lot of the ones that were studied, like in like the Shuba study, or a lot of the ones that were looked at in Shuba study, and some of the other ones are not readily available inflammatory mediators that we have to look at. So sometimes we're relegated at looking at things like, ferritin, fibrinogen, both of which are very, flawed metrics. CRPs, also not the best metric. But I do look at those. What I probably at the end of the day put most of my stock in, though, is what I'm able to see on ultrasound, doing things like looking at the right ventricle, looking at the TAPSE, the S prime, looking at the RVOT VTI. I love point of care echocardiography, so I do a lot of that. Looking at IVC pulsatility index, looking at the hepatic vein, seeing if they have reflux or not. I take a lot of those echocardiographic or ultrasonographic findings into account, and then kind of pair that with what I'm seeing from an inflammatory perspective, and that's what kind of guides my decision making, both in terms of ARDS management and sepsis management. If I have a CVP, I might look at that. If I have a BNP, I'll look at that, especially if the patient's demonstrating evidence of right heart failure, or if they are, maybe a candidate for ECMO. So it's really less. I do my best to do what I suggested AI can do better, which is take all that into account and make the best decision I can make.
Thank you.
Let's see. I did see this one question. Major problem I saw height of COVID pandemic was low pH associated with hypercapnia. Okay, could not occur. If I would bring back non-bicarbonate buffers, and I'm surprised this hasn't been re-examined. Any synergy? So I am not familiar with any active research in that vein. But you're absolutely right. The hypercapnia, I think, is refractory hypercapnia in ARDS is not really should not trigger CRRT. You can sort of put a Band-Aid over the bullet hole, maybe with CRRT, but really that should be triggering at least something like ECOR, which is like kind of baby ECMO, or these are patients that should be put on ECMO. And that's how you're going to fix their refractory hypercapnia. So,
Any other questions? Okay, thank you so much.
absolutely. Thank you guys so much. It was great to come home, if nothing more virtually. I appreciate it.